Lee from the Hepatitis B Foundation, where I'm the program manager for the Foundation's liver cancer program called Liver Cancer Connect. Today's webinar, Treatment Options for Liver Cancer, is presented by Dr. Robert G. Gish, a world-renowned expert on liver diseases. Dr. Gish is a professor consultant at Stanford University in California and serves as the medical director of the Hepatitis B Foundation. Today, Dr. Gish will explain how detecting liver cancer early through screening and surveillance can help increase the number of treatment options and the chance of successful treatment. Dr. Gish will also review some of the promising new treatment strategies that are currently being studied in clinical trials. You're welcome to send in questions using the chat box feature. This is located in the control panel on the side of your screen. We'll try to address as many of your questions as possible. We'll also be posting the responses to all the questions later on our websites, livercancerconnect.org and hepb.org. With that, I'll hand it over to you, Dr. Gish.
Good morning, everybody. I hope everyone's well on this wonderful Monday. And we're going to be talking about a very important topic that's a world health issue as well as an issue in the United States. And I'm just trying to get my mouse to move things forward. There we go. I think we're in good flow here. And what we're going to be talking about today is natural history, testing, surveillance, terminology, what you need to think about as a patient or a patient support person, and think about what the world is in terms of liver health as well as liver disease. Here we have a diagram of a healthy liver. And of course, there's a number of intermediate steps between that healthy liver and a cirrhotic liver, which you see this very ugly organ that's large and what we call hobnailed. And then there's a cross-section on the right of that liver where they've cut across, and this person sadly had a number of different cancers inside their liver. There are chemical signals, genetic signals that tell signals when to grow out in a healthy manner, when to slow down or when to stop, and then when those signals are bad, the liver cells can grow in an uncontrolled fashion. And the classic setting is something like viral hepatitis. Of course, hepatitis B is #1 in the world in terms of causing liver cancer. And interestingly, hepatitis B causes liver cancer both through inflammation and causing direct liver damage, turning on and turning off different genes. And then it also goes inside the genes, the genetics of the liver cell to turn on and off genes that could control cancer or signal cancer. Cirrhosis is that term we use for scarring of the liver, and there are many causes of cirrhosis. Sadly, sometimes in the community, when someone says the word cirrhosis, they immediately link it to alcohol, but in the world, alcohol is a distinct small portion of the causes of cirrhosis and liver cancer. You don't have to have cirrhosis to be at risk for liver cancer, and that's most commonly if a person you know or if you have hepatitis B. But there are some other special settings that can cause cirrhosis without, can cause cancer without having cirrhosis. So work with your provider to determine if you are at risk, if you've got some type of chronic liver disease. That should be a discussion that would happen at least every 6 to 12 months with your regular appointments. And if you have liver disease, make sure you're getting regular appointments with a provider. And that is something that happens. Some people say, well, I feel well. So 3 or 5 years sometimes passes. And sadly, we may miss a cancer in those patients and we have it diagnosed late. And let's see which of my controls moves these slides forward. I know there's a little bit of a delay sometimes, so I tried my page down. Oh, it looks like it's my right button that works. On this slide, we talk about what can lead to liver injury. Up in the upper left-hand corner, we're talking about viral hepatitis B or C or alcohol. We've mentioned that. Fatty liver is the emerging crisis in liver health and liver disease because of the obesity and diabetes epidemic. We'll talk more about that shortly. Iron can hurt the liver. That's typically genetic. And then there's some environmental toxins and aflatoxins in southeastern China, Southeast Asia, and Africa as a pro-liver cancer toxin that comes from mold that's on different types of grains, such as rice or wheat. Then you get this chronic hepatitis, as we talked about. You get the scarring of cirrhosis and then uncontrolled cell growth. Then down at the bottom, we just talk about the timeline between each of these events, although young children can get liver cancer. But this is a typical pattern of disease to cirrhosis, and then once people get cirrhosis, the timeline to liver cancer, which explains about 85% of liver cancer. So 5% of liver cancer is very early without cirrhosis. Another 5 to 10% of liver cancer can be mid to later years in life, also without cirrhosis. So keep all those in mind and talk to your provider about risk and about testing or surveillance. There's a spotlight on prevention. You can prevent, of course, cancer by preventing hepatitis B and C. There's a hepatitis B vaccine that's really an anti-cancer vaccine because it's extremely effective at preventing hepatitis B transmission. There's no vaccine for hepatitis C, but we've got new treatments that have an extremely high cure rate, the 95% range or higher. And by curing hepatitis C, you can prevent cancer. You can markedly decrease the risk of cancer. Even somebody who has cirrhosis with hepatitis C, once their hepatitis C is cured, their cancer risk falls. You want to prevent cirrhosis, so tell people not to drink alcohol if they've got liver disease of any cause. If you've got fatty liver, people shouldn't be drinking alcohol. And of course, to prevent fatty liver, you have to have a healthy weight, and we calculate that weight by what's called a BMI. Everybody should know their weight, and everybody should know their body mass index. Very simple calculation you could do online or with your provider. These are very, very important points. Let's start at the beginning. Screening is the first test. Surveillance is regular testing. People with chronic hepatitis B, we have very specific guidelines and thresholds to do regular testing. Let's say I'm seeing a patient who's a 22-year-old person who's born in Africa, who's an immigrant or an African American with hepatitis B. Because of differences in genetics and risk, I'm going to start doing surveillance, ultrasound testing, imaging of the liver with blood tests at the age of 22 in that individual. Let's say I have a man from Thailand who's 50 years of age. He doesn't have cirrhosis. His hepatitis B is under control, either through his own immune system or maybe the application of a medication. I'm going to start surveillance for that 50-year-old man. Actually, I start at age 40, but I'm just using this as an example that age, even without cirrhosis, would start regular testing in those individuals. I believe we've shown compelling information that early diagnosis leads to better survival. Cure offer for many patients, either through transplant, surgical resection, or ablation. And this early detection also allows us to move through multiple options and also to treat the underlying liver disease. If a person has liver cancer and hepatitis B, we treat the cancer and we treat the hepatitis B. We work on nutrition. We try to decrease or treat fatty liver if that's in the background. We counsel them to stop alcohol. We might implement vitamin D supplementation, which many of us think decreases the risk of cancer or cancer recurrence. Statins to treat cholesterol actually have an anti-cancer effect. And of course, early cancer detection, because transplantation, liver transplants in short supply, we want to get them on a transplant list to maximize their chances of getting a transplant. It's an issue in the U.S. and an issue globally. Now, who needs liver cancer screening and surveillance? We always look to the AASLD guidelines. In Europe, there's the EASL guidelines. In Asia, there's the Asia guidelines. There's a number of different guidelines, and they overlap very, very well. And an example would be women with hepatitis B without cirrhosis. They're at risk for cancer, marked increase after age 50. Any hepatitis B patient with cirrhosis, you start surveillance with blood tests and ultrasound. If there's a family history of liver cancer, or maybe the family history is unknown, we're going to start liver cancer surveillance earlier. Asia and Pacific Islander immigrants and their children, we're going to think about surveillance earlier, again using family history, how high is their viral level in their blood, if they're treated or not, indirect assessments of advanced fibrosis. And then if people have co-infection with HIV, hepatitis B, or hepatitis C, or what's not on this slide is delta hepatitis, all of those increase the risk for liver cancer, just as if you had hepatitis C and, say, fatty liver. In the U.S., there's 3 biomarkers that are FDA cleared, not to diagnose liver cancer, but to assess for risk of liver cancer. This is what they are under FDA approval or clearance. These are risk markers. So ultrasounds are not perfect. If somebody's heavy and ultrasound's less accurate, there may be movement, there may be anatomical access issues. So we want something to help us with our ultrasound surveillance to decide when to do CT or MR scans, which are much, much more expensive. CT scans have radiation. MR scans take a lot of time and are about twice the cost of a CT scan. So these biomarkers help us decide whether somebody is in a safer category or a higher risk category. The more these are elevated numerically by the numbers, or the more that are elevated. If you have 2 out of 3 or 3 out of 3 that are high or abnormal, there's a higher future risk of cancer. And these often go up before a cancer can be seen on imaging. So talk to your provider about these FDA-cleared biomarkers. A little bit more on cancer screening and surveillance. We're going to look for complete blood count because we assess fibrosis indirectly in many of our patients. But if you have a patient I'm talking to or a family member, we're going over lab tests and the platelet count is low. Many of you have heard of that word platelets. It's a little cell fragment that's in your blood that helps with clotting. If the platelets are low in somebody with liver disease, 95, 99% of the time it's due to the fact they have a large spleen, and the spleen may be enlarged because of liver damage. Liver damage, cirrhosis, fibrosis backs up blood into the spleen, making it big and decreasing the platelet count. It's an indirect assessment, but it's free, and then we can use that in combination with other blood tests and with imaging studies and put all of these things together. There's no one test that indicates risk and the presence of or absence of cirrhosis. We're going to look at 5 or 6 or 7 different parameters to make our final decision. Diagnosing liver cancer now is not made by biopsy. It's quite strange. Every other cancer that I can think of, the oncologists, the providers that take care of these patients want to have a biopsy. At this time, we make the diagnosis by CT or MR scan using very specific criteria. MR stands for magnetic resonance. CT stands for computed tomography. Those are special tests. One uses a big magnet. The other one uses radiation with a contrast agent. And then we think about doing a biopsy only in special cases where things are indeterminate. We can't really decide what we're seeing on the pictures, or if we're going to put that patient into a research trial. This is going to change. In my prediction, most, if not all, liver cancers will be biopsied in the next few years as we do what's called personalized medicine. So discuss the need for a biopsy. The risk of spreading cancer with a biopsy is far less than 3 in 100 biopsies. It's probably about 1 in 100 biopsies. And the risk of bleeding is quite rare. Of course, there are high-risk patients for bleeding with biopsy, but most patients, that risk is minimal and very, very small numbers. So we think soon the balance of benefit to risk will point us to doing biopsies in many, if not all, patients. But that's looking out into the future a little bit, not necessarily applicable today, but definitely talk to your provider about that question. Staging. We want to know if it's early, middle, or late. Is it local? Is it spread locally? Is it spread regionally in the abdomen, around the liver? Is it spread throughout the body? So we stage patients. And it's not just staging the cancer because liver cancer operates in the background of liver disease. So we stage the liver disease. And most importantly, we're looking at a patient. We want to stage that patient in terms of how functional they are. Can they take care of themselves? How much symptoms do they have? What's their nutritional status? All of this overlaps into a multi-layered assessment to stage the cancer, but more importantly, stage that patient and their liver cancer and how they're interacting. And there's probably 10 different staging systems. The one we use in the U.S. is called the BCLC. It started in Barcelona, but we're now going to talk about something called TNM because it's so simple. 1, 2, 3, 4. 1 is a small liver, one small part of the liver. 2, several tumors that have spread potentially to local blood vessels. 3, tumors that have spread to nearby parts of the body around the liver. And 4, distant cancer. So talk to your provider, talk to your patients, families, your support about these scoring or staging systems, and think about how that's going to interact with what you decide to do next with your provider, with your life, with your cancer. Now we're going to move to the next phase of this presentation called managing liver cancer. An individual treatment plan has to be established for every patient. Liver function, AST and ALT, are not liver function tests. These are liver enzymes. Make sure that terminology is clear between you and your provider. These are liver enzymes that are part of a liver panel and often are called liver function tests by different providers, but the right name is liver enzymes. The best liver function tests are bilirubin, which is a chemical that makes your eyes yellow if it's high, albumin, which is a protein that if it's low, you get swelling, and finally an INR, which is a coagulation test. We're going to stage that cancer like we talked about before, but be more specific now. We're going to talk about the number of cancer tumors inside the liver and whether it has spread to blood vessels. And is it distinct? Is it well marginated? Is it in one part of the liver? Has it gone to the capsule of the liver, outside the liver, into the diaphragm? We're going to take pictures of the lungs. We may do bone scans. And we're going to say whether this is local or not. And like we talked about, the health, the nutrition, the functional status of that patient is very, very important. This is holistic medicine really being applied. And this is what happens when you get with your liver cancer treatment team. Everybody who's got liver cancer, in my opinion, should have a combined team of a hepatologist, liver specialist, which could be a gastroenterologist, of course, and those liver specialists are often partnered with nurse practitioners, PAs, or nurses. Pharmacists are important, but very important is having a surgical colleague where there's a high-level dialogue about what to do next. You want a surgical team that's not too conservative, but not too aggressive. And that surgical team has to be partnered with an anesthesia team and an ICU team that can really help take care of that patient. Radiology we talked about, they're essential for diagnosis and also for potentially treating cancers, which we'll talk about how that interventional radiologist can intervene in this disease state. The medical oncologist that's got a special interest in liver cancer is an essential part of the team. We partner with these experts all the time, and they have a lot of input. They have clinical trials. There's just so much that can be gained by having this very dynamic interaction. Radiation oncologists are also occasionally used in our patient management. Liver transplantation is the best way for early cancers to result in a cure. There has to be a tumor, single tumor less than 5 centimeters, or up to 3 cancers, with the largest of 3 cancers being 3 centimeters. Once you get outside these parameters, the chance of the cancer coming back goes up markedly. And so you know we have only about 6,000 livers per year, and we have about 35,000 people with liver cancers each year. That's why we have this heavy focus on prevention and, of course, treating the underlying cause of the cancer once it occurs. We're trying to prevent the cancer by suppressing or curing virus or stopping alcohol or getting people to lose weight. Orthotopic transplant is using a healthy liver from a person who's recently died or using part of a healthy liver from another living person. place where I work at Stanford does live donors in both children and adults, and I think this is an important tool, not for every center to perform, but every time a patient needs a liver transplant, live donor liver transplantation needs to be discussed with that patient as an option. Surgery? Yes, we can cut out the cancer, but remember, we're not cutting out the rest of the diseased liver. So there's a background environment where cancer can recur or occur in that remnant liver. To go through surgery, you have to have good liver function, and this means early cirrhosis, and we're going to treat while we're waiting for surgery or setting up the surgery, suppress that hepatitis B or C and try to get that fatty liver at least partially treated or reversed. The surgeons have gotten much, much more aggressive recently with managing liver cancer surgically because of advanced surgical techniques, and they can treat the tumor, shrink the tumor through some of the things we're going to talk about next, and bridge back to surgery. Just imagine you've got, you as a patient, you know somebody who has severe hepatitis C, but we cure the hepatitis C. The liver function gets better in 2 or 3 months, and I've seen this happen frequently. Suddenly, somebody who was not a surgical candidate becomes a surgical candidate. So these are all important discussions and to rediscuss on a monthly or 2-month basis. And I'm going to guess really at this time 1 in 7 patients with liver cancer is resectable, but I think that's going to increase to about 1 in 3 in the next 2 to 3 years with our advances in treating hepatitis C, curing hepatitis C, improving liver function. What about localized treatment? You find these smaller tumors early and you're waiting for a transplant, or you're not sure that you want a liver transplant, and maybe you've got something else that might be a contraindication to a transplant, a reason you can't get access. And these are different methods of putting probes or catheters inside the cancers and heating them, or cooking them, or delivering embolic material, which cuts off blood and oxygen, or can deliver chemotherapy or radiation therapy right inside the tumor itself. And in early tumors, some of these are actually curable. They're equal to surgery. So we really think about that. And I really want you to have an in-depth discussion about the size of the cancer if you have a cancer, know somebody that you're supporting that has a cancer, and talk about a staged procedure. You can imagine that one could go in through the artery, shrink the tumor maybe by 80%, come back with a thermal catheter or probe, heat up the rest of the tumor, and suddenly you've got a tumor that is actually shrunk by 95 or 97%. But let's say there's still a little bit of cancer left. During this time, you've treated the hepatitis C, the bilirubin has gone from high to normal, the hepatitis C is cured, the platelet count has gone up, the varices, these are veins in the esophagus, have disappeared. Suddenly, going back to the surgeon may be an option to talk about resecting that cancer. Here is a diagram of an RFA or microwave probe. You stick that into the tumor, you turn on a button, and it heats up the tumor from the inside out, cooks the tumor, and this has minimal risk of bleeding or spreading the cancer. And believe it or not, in smaller tumors, this is a very important point, can result in a cure. Now, I talk to my patients, the chance of this curing their cancer might be 1 in 5 or 1 in 6. But while they're waiting for a transplant, or maybe they're not a transplant candidate, that's a huge number when they've gone from a 0 cure rate if there's no intervention. Pain and bleeding can happen. They're usually early, they're minor, and tumor tracking or seeding is also very rare. This is considered frontline therapy, standard of care for specific patients. Tumor size specifically, we'd like to have less than 5 centimeters, preferably in the 2 to 3 centimeter range. And remember, an inch is a little over 2 centimeters. So a tumor that's an inch or inch and a quarter would be ideal for this in terms of a single therapy. This is a diagram of bead embolization or chemoembolization. TACE is where there's an oily material with chemotherapy, That big red tube on the right side of this picture is the aorta. The radiologist places a catheter down in the groin area, down by the leg, where the leg joins the hip, and that catheter goes up into the artery. It's a plastic tube. It goes out into the artery that feeds the tumor. And into the tumor, you can drop this oily material with chemotherapy. You can put in something that cuts off oxygen. You can put in plastic beads that release chemotherapy. And on the left side of this is what's called the portal vein. That's the other blood supply to the liver. The liver is very interesting. It gets blood and oxygen and nutrients from two major vessels. And what is done at some centers is they go into the portal vein, and the part of the liver where the cancer is, they'll clot off that part of the liver also in the vein, and the other part of the liver regenerates and gets larger. This further helps the surgeon later, possible, to think about a staged procedure, shrinking the tumor and increasing the remnant, the remainder liver volume to make them a better surgical candidate. So this is a very interesting option. Hundreds and thousands of these procedures are done in the United States each year. If you have a tumor you can't get to with that catheter, that little probe that cooks the tumor, very important. You can use this technique. Or maybe somebody has a little fluid around the liver, a little ascites, or maybe their liver function's a little bit worse, and you can use this selected therapy. Very commonly used. We believe this prolongs life. We believe that this bridges patients to transplant or surgery. A little bit more about this localized treatment by delivering these plastic beads with chemotherapy. What's really nice about this is that you've got a very controlled method of delivering the chemo and the beads, and there's much less side effects. This decreases the amount of chemotherapy that spills into the bloodstream, and you really get your local effect, but not a systemic effect. Now, these tumors can be up to 7 to 9 centimeters. When it says here kills most, meaning it kills most of the tumor. But this is rarely a curative therapy unless the tumor is quite small. Improving survival in liver cancer is important. We think that these chemotherapy or bead embolization improves survival according to some different publications that have been shown. The bead embolization may be a little bit better than TACE, although that's a little controversial. We know there's less side effects, it's more controlled, and that's why many and most centers use beads over chemoembolization, although a number of centers still use chemoembolization using what I call microfine catheters, and in selected patients, TACE may be better. So that's a discussion between the provider team, the patient, and importantly, the interventional radiologist, who I said before is one of the 4 or 5 wheels on this car, this transportation we're taking to better survival for liver cancer. A little bit more on localized therapy. Radiation therapy can be beamed externally into the cancer. Also, there's a transarterial bead. You can deliver plastic beads or glass beads with radiation therapy. And we are finding both of these to be useful, again, in selected patients. TARE is very useful in patients with large tumors, especially if there's blood vessel invasion. Targeted therapies. We're now going to talk about more of a systemic approach. In the history of treating liver cancer with something that's infused into the blood or a pill has really been fraught with failure after failure over the last 30 or 40 years. Now, this has changed recently. There was a medication, I'll call it a designer medication, although it was designed for a number of different cancers, called sorafenib. There's a brand name called Nexivar, but we're going to use the chemical or generic name for this purpose of this discussion. And this comes into the body, gets delivered to different parts of the body, but heavily focused on the liver cells, and targets those liver cancer cells and blocks 3 different pathways in that cancer cell promotion. These targeted therapies are going to be developed from many other companies, and there's hundreds of clinical trials and at least 10 new medications that we're going to be looking at. And we'll get to some more details on that in a moment. Sorafenib is approved in over 70 countries. It blocks tumor signaling. And one of the ways it works is by decreasing the formation of blood vessels that provide oxygen and nutrients to tumor cells through a receptor called VEGF, V-E-G-F. What to ask your healthcare team? What are my treatment options? How will they help? If I have hepatitis B or C, should I undergo antiviral treatments? What do my blood tests show? Please explain those to me. Please go over my imaging results. I'd like to look at the pictures. I'd like to have you show those to me if it's possible. What's my team say? What's the multidisciplinary team advising for this treatment process? The treatment, what are the risks? What are the benefits? I want to know about side effects, short-term and long-term. What's the chance the cancer won't be fully treated or come back in another part of my liver? I tell all my patients to carry a copy of their results wherever they go, a full medical chart. It's nice to have it electronically scanned as well as a paper copy in a folder. Patients come in for an appointment and they say, you should have my results. And I don't have any results because the fax system's down or there was a delay getting it into the electronic medical record. So take that level of responsibility for your care, your family members' care, and get copies. You go get an x-ray, get a disc, get an MR, ultrasound, CT, get it on a disc, carry that with you, and you can offer that to providers that you see, but ask for those records back, the disc back. Life after treatment. We are focusing on prolonging life, curing cancer potentially, improve quality of life, or at least not making quality of life worse. You may have side effects of these different treatments. We talked about sorafenib. It definitely has side effects to the skin or GI tract with fatigue. Stay active as best you can, even if you're tired. Try to get some exercise 3 to 5 days a week, even if it's a light exercise. Eat frequently. It's interesting with cirrhosis that eating 5 or 6 small meals a day is much better than 3 large meals. Lower fat diet is easier to digest. You need protein, call that 100 grams of protein a day, and you can calculate that. Coffee and tea are very safe, and actually, interestingly, are probably the only plant-derived substances that are good for your liver, anti-inflammatory and anti-cancer. So instead of taking milk thistle, go to Starbucks or, one of your local coffee shops. Green tea has some of these anti-inflammatory and anti-cancer chemicals as well. Be compliant with your medical follow-up. Ask questions. Take notes. What about a general wellness plan? Work with your primary healthcare provider. Work with your nurses and NPs and PAs. All very important part of these teams. And if you've got cancer, your cancer testing or disease testing in your family should take place as well. And here's a website where you can get more information about liver cancer. A little bit more information to go here. We're moving through our presentation, getting close to the Q&A, and trying to get the slides to go forward. Let me see if I can get those to advance. I don't know if the team could maybe help me. Oh, here's a little bit more. Thank you. Medical follow-up visits we talked about. Follow-up imaging typically every 3 months. Blood tests every 1, 2, or 3 months, which you should continue for years after surgery or liver transplant on a regular basis. Keep your health insurance. Health insurance things have gotten a little bit better this year. There's always controversy there, but more people are covered, which is helpful. Again, keep records of your blood tests, imaging, surgery, discharge reports. Always have an active list of your current medications and provide that to each provider with each appointment and carry that with you in case you need to go to the ER, talk to your pharmacist about drug side effects and drug-drug interactions. What's in the pipeline? There's a lot in the pipeline. There's 1 million liver cancer deaths each year in the world. United States, 35,000 new liver cancers each year. About 22,000 of those are dying. Well, you can target the cancer. You can use combination, immunotherapy. You can deliver chemo and radiation directly into the tumor. You can attack proteins that help tumor growth, and here's a list of different types of anti-cancer medications that are being developed. You can target cancer stem cells. We're not really doing stem cell therapy yet for cancer. And remember, stem cells are one of the sources of cancer, so we have to be careful with that. And we're looking at combination with sorafenib, with chemotherapy and some of these different ablative therapies that are there. And maybe even something called proton therapy. There's a few centers in the country that have proton treatment. Let's see, just going to go forward one more slide here. Looks like the slides are a little bit slow. Immunotherapy, these are immune system tools that kill cancer cells. We think that cancer suppresses the immune system. It doesn't depend on liver function. You boost or enhance your inherent immune responses. We believe this can be combined with ablation. It's in research right now, but we think this is going to be one of our powerful tools. Well, what are those types of immunotherapy? Well, there's this very fancy name called checkpoint inhibitors. Some examples of those are enhancers of what are called, or block what's called PD-1 or PD-L1, which reboosts the immune system. There's cancer vaccines that directly encourage the immune system to attack proteins that are on the cancer cells or targets that are on the cancer cells, which may be modified proteins, what are called glycoproteins that are there. Then what if you can take the patient's immune cells, modify those, and then attack the cancer cells, called adoptive T cells. T and B cells are part of the immune system that help control infection, but they also are very important for cancer. Monoclonal antibodies. These are single antibodies that target very specific sites on cancer cells. Cytokines are messengers that are involved in immune or inflammatory response that can attack cancer as well. And there's some viruses that can be modified that turn the tumor on or off or cause the tumor to self-destruct. These are all in the works today. Very exciting times. It's a huge investment from the pharmaceutical community, research community, and investor community, the people that put their money out on the line for this type of treatment process. Ramucirumab is interesting in the phase 3 study. It improved overall survival, but it wasn't statistically significant, which is interesting. And this is really a problem with study design for liver cancer trials, because in this trial, plus some other recent medicines, subgroups of patients clearly benefited from the anti-cancer therapy. Liver cancer is heterogeneous, meaning one person can have one type of cancer, or they can have a cancer that has 4 types of cancer inside the single cancer. And that goes back to customizing, picking the right drug for the right patient and the right tumor. And we're on our way to do that. It might still be 1 to 5 years away. And we are looking at some other drugs, nivolumab, tremelimumab, all looking at monitoring or treating cancer with different targets. Clinical trials determine whether a drug is safe and effective. I encourage all patients with liver cancer to discuss clinical trials with their providers. There's a chance that you may get placebo, but this depends on if you have an early or late cancer. And if you were to be assigned to a non-treatment arm or a placebo arm, would you later have the option of getting treatment? These are all things that you need to discuss. Liver cancer clinical trials will be on a webinar in just a few weeks, Wednesday, May 27th. You can register at this livercancerconnect.org website. Please join us for that event. Here's a picture of the livercancerconnect.org website with liver cancer centers, drug watch, clinical trials, information for newly diagnosed, talking to your healthcare team, treatment options. Liver Cancer Connect has a drug watch site. Here's all of the different medicines, how they work, where the company is, FDA approval process, phase 1, phase 2, phase 3, preclinical. Take a look at this. This is a very important website. Key messages. Know if you have liver disease. Know your risk, family history, hepatitis, cirrhosis, all perform an assessment of your chance of having liver cancer. Blood tests, we talked about risk markers for liver cancer that are FDA cleared. Screening and surveillance. Early diagnosis saves lives, increases the chance of a cure. Symptoms of liver cancer are often very late. So even with minor symptoms, ask the question, 1, do I have liver disease? 2, what's the cause? 3, how good or how bad is my liver? What stage am I at? And then 4, if you have liver disease, in my opinion, everybody needs a baseline imaging test, at least a full abdominal ultrasound. You combine that with the stage of the disease by blood tests, by other assessments, talk about cancer risk, and also making sure you don't have cancer at that first assessment. There is evidence of something abnormal on an ultrasound. Moving to a CT or MR scan is critical to help make that diagnosis. And as we talked about, discuss a liver biopsy, a tumor biopsy to see if that's needed. There are many treatment options. There should be a treatment team, clinical trials for liver cancer. It's time now for Q&A, and I'll turn this back over to Anu and the team. This is the Liver Cancer Connect project. I want to thank the Hepatitis B Foundation and all of our supporters. And we can go into Q&A now and see what are pressing issues, key questions that you may have.
Thank you, Dr. Gish. That's a very informative webinar. And we did receive some questions, and I'd like to run through as many of them as possible with you. For the first one, how long can you afford to wait for an appointment to see an oncologist? Do I have to see one immediately, or travel to an expert, or go to a well-known cancer center?
So if a person's been told that they have liver cancer because of the urgency of intervention, the anxiety that a patient's family and support system may have, I think you should be seen within 10 working days. So if you're diagnosed on a Monday, you should have an appointment with a liver cancer expert by the following Friday at the longest. There's really not much reason to wait longer than that, and it'll lead to further delays because usually there's more testing required. So really put pressure, less than 2 weeks, 10 clinic days, 10 working days or less.
Okay. Another question. When should I get a second opinion, or should I get a second opinion?
Well, let's say that you live in rural Oklahoma and you're being taken care of by a local oncologist, and you ask the oncologist, how many liver cancers do you see a year, or do you take care of each year? If that person says between 1 and 5, I think it's very reasonable to get a different opinion, to get a second opinion from somebody. You really should be working with somebody that's managing at least 10, preferably 50 or more liver cancers per year. Same thing with a gastroenterologist. If a gastroenterologist diagnosed a liver cancer, how many do you see each year? How many do you work with oncologists? It's really hepatologists now that do the lion's share of liver cancer management in partnership with specialty liver oncologists, liver cancer oncologists. And that, to me, is the magic combination. We have to have supplements by highly skilled surgeons that have excellent bedside manner, as well as operative skills, good judgment, not to push things too far, to take too high a risk with patients, yet still provide the highest level of care. And of course, we've got our interventional radiologists, not just our regular radiologists who help with the diagnosis. So you're going to get these at liver cancer center teams, typically with liver transplant centers is the most common, but there's other places. I work in Las Vegas and Reno, which don't have liver transplant programs, but they've got very skilled liver cancer management teams. So seek those people out, seek those centers out, very important.
Okay. We have a question here about biopsies. You mentioned that diagnosis is done by imaging, but then biopsies are used to confirm a diagnosis. Is a biopsy safe, and is it necessary?
We perform liver biopsies now in less than 5 out of 100 liver cancer patients. We don't use them to confirm cancer. We confirm cancer with imaging in 95% of patients. 5% of patients have indeterminate imaging tests. I'm being general here. It might be 7 or 9 or 4%, but it's a small number. In those indeterminate cases, we move to biopsies. We're also doing biopsies to get patients into new clinical trials where we have targeted therapies where we need biopsies on a research basis to do personalized medicines. So biopsies are important to discuss. They're important to apply in special situations. That should be a team decision with the provider team and the patient's family. The risk of bleeding or pain or spreading cancer is very low in most patients. There are high-risk patients for those, but most patients, the risk is very, very low. So that should not be a major deciding factor whether to have a biopsy or not. Will it change management? That's the question.
Okay. I have a question here about the surgery or resection. If my tumor has been removed successfully, does it mean I'm no longer at risk for liver cancer? And how long am I followed up?
Surgery results in a cure, a 5 to 10-year cure, in less than 30% of patients. The inverse of that is 70% of patients or more who have a surgical resection, cutting out the tumor, the cancer will come back in less than 5 to 10 years. To decrease the risk of the cancer coming back, you have to treat the underlying disease, the hepatitis B, the C. Stop drinking alcohol if you're an alcoholic. If you're obese, if you're fat, you lose weight, treat the fatty liver. But cancer comes back after resection in the majority of patients. These biomarkers I mentioned help determine the risk of post-resection recurrence. In some people, the cancer comes back, then they're moved to transplant, or they're moved to other types of ablative therapies. So a person can move through 3 or 4 different types of therapy to prolong their life. Cure with surgery is in a minority of patients. There are exceptions. The smaller the tumor, the better the liver health, the higher the cure rate.
Okay. Now a question about viral hepatitis. If I have chronic hepatitis B or C and I'm diagnosed with liver cancer, do I have to be treated with antiviral agents first, or do I have antiviral treatment along with the treatment for the cancer?
You start the treatments at the same time. You get on that hepatitis C drug as soon as possible. Same thing with hepatitis B. Hepatitis C right now is a little sad. The insurance companies have put up huge barriers to accessing these hepatitis C drugs because, well, they didn't see the semi-truck coming down the highway. They were sort of, walking out on the freeway and not thinking that there's any, new treatments coming, and they didn't budget for the cost of that treatment. So it's quite an interesting situation. But the final answer, treat the B, treat the C immediately as you're considering other steps and other options, okay?
Okay. And would I then have to be on lifelong antiviral therapy?
For hepatitis C, there's a cure. So it's 12 weeks for most people. For hepatitis B, it's indefinite.
Okay. And you talked about the sorafenib, the targeted therapy. Can that be used in all patients, or which of the patients that it's used in?
It is used in patients with unresectable cancer, most commonly when they're not candidates for these other ablative procedures, either the heating of the tumor or the therapy through the artery, and definitely used in patients with cancer that's spread outside the liver, metastatic disease. So large tumors that are in the liver and tumors that have spread, the patient needs to have a bilirubin less than 2 to 3, meaning good liver function. It should be in good health and nutritional shape. The medicine does have side effects. Diarrhea, fatigue, and a skin reaction are the most common. And about a third of patients, in my experience, who take sorafenib have quite a profound response. You never know until you treat people. So number one, a third tend to fall off therapy due to side effects. Another third don't respond because their tumor is different than what sorafenib targets. But a third can tolerate the side effects and can get extensions of life that I have seen go out as long as 30 months. It's quite interesting with this medicine. But I offer it to everybody if they fit the profile. I look for that third that have that profound benefit.
Okay. Now on to the immunotherapy. Will immunotherapy drugs have fewer side effects, or will they be less toxic than what's currently available?
We don't know. This is all about clinical trials and profiling patients in those clinical trials. So let's say we're going to look at that information as it emerges, as these drugs get the FDA approval. I hope they're less toxic, but until I see the phase 3 studies, I just don't comment.
Okay. And some immunotherapies can't be used in people with chronic hepatitis B or hepatitis C. Why is that?
Well, we actually don't know that. These drugs that I call PD-1 or PD-L1, these are drugs that are checkpoint inhibitors that modulate the immune system. They may actually have an antiviral effect. The companies are being cautious with those medicines, making sure they're not causing flares of liver disease as say the immune system turns on the cancer. It may turn on the virus and cause liver damage, but we don't know about that yet. It's a wait and see process. We're going to have to see. But the companies are very interested in these immunotherapies, potentially to fight hepatitis.
Oh, wow. And the final question about standard chemotherapies. Why doesn't that work in liver cancer?
Well, you have to give these high doses. They spill out to the entire body. And because you can't target the chemotherapy right into the tumor, you end up causing damage to the heart or bone marrow or other parts of the body. So targeted therapy that gets delivered to the liver, targeted therapy that's specific to liver cancer tumor changes, the abnormalities in those liver cancer cells, is really the future. And this is what's happening across all cancers: lung, melanoma, breast, every type of cancer. We're targeting what's wrong in the cancer, not necessarily just the cell type or the tissue where the cancer came from.
Okay. And we have one final question about transplant. What are the chances of a cure with transplant?
If a person gets a liver transplant and they fit that criteria, up to 5 as a single tumor, up to 5 centimeters, or up to 3 centimeters as up to 3 tumors, there's an 85% chance of being alive at 5 years with no cancer. It's a really, really good long-term survival with liver transplant. Selecting the right patient, good patient management, being in an expert transplant center, you put all that together, there's an excellent 5-year survival. That's what I think it will look like in the next 5 years.
Oh, good. I don't have any other questions here. Do you have any other points that you'd like to make, Dr. Gish, to point out to, or some key takeaways?
Well, I think it's screening for liver disease is essential. Getting into an expert that manages liver disease, which might be a primary care provider, NP, PA, does not have to be a hepatologist at a transplant center. Staging liver disease, finding out who's at risk, doing regular surveillance, calling people back. But the patients need to take a responsibility in that testing process. If they're told to come back every 6 months, they need to call and make that appointment, make sure they get the right blood tests and scans done. They need to be a partner in their own health, in their own surveillance. Once you have cancer, work with an expert team of liver cancer specialists. Very, very important to have that take place. And then work, ask questions, stay in good health, good nutrition, exercise, work with your support to make that quality of life excellent. If you're not curable, we can still prolong life for many patients for months to years with the right team approach. And I want to thank the Liver Cancer Connect and the Hepatitis B Foundation, Hepatitis B United, for this incredible opportunity.
Thank you, Dr. Gish, for a very informative webinar, and we hope that you will all also join us in our other two webinars. We have one coming up on May 27th, as Dr. Gish pointed out. It's clinical trials in liver cancer. That'll be at 1:30 U.S. Eastern Time on May 27th. And then our third webinar will be support services for families facing liver cancer. It will be on Wednesday, June 3rd at 1:30 p.m. U.S. Eastern Time. You can find the times, dates, and registration links for those webinars on livercancerconnect.org and hepb.org. Thank you again, Dr. Gish, and thank you everyone for joining us. This concludes our webinar.